Please rename Arun, sir.
Yeah. Abhishek, can we start now?
Ma'am, just a minute.
Yeah.
Please rename Arun, sir.
We are good to go, ma'am.
Yeah. A very warm welcome to all the delegates who have joined in. A welcome to all the esteemed faculties from the East Zone. This is the 11th episode of Public Awareness Committee Fogsi webinars, which we conduct every 15 days. Taking into consideration that June is an infertility awareness month, and we also celebrate the Environment Day, we have selected our topics wisely, saying the environmental factors affecting infertility and optimizing the results of the fertility treatments. We are also happy that we have also conducted a each one teach one competition where we have more than 35 entries from various societies, and there are more than 500 individual entries also. So each one of us has contributed to this environment in some way or the other. We welcome all the dignitaries for an inauguration and e-lighting ceremony. Can we have the Saraswati Vandana, please?
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्योर्मामृतं गमय ॐ शान्ति शान्ति शान्ति.
These webinar series are a brainchild of Dr. Priyankur Roy, who is the chairperson of Public Awareness Committee. Under his able leadership, our conveners, Dr. Rekha Jha Madam and Dr. Indranil Datta, who are the coordinators for the East Zone, have put in lots of efforts for this webinar too. I welcome Rekha Jha Ma'am to give her comments. Ma'am, are you there? Rekha Ma'am? I can see her, but she is muted, sir. We can
Yes,
go
yes,
ahead.
I'm there.
Yes, ma'am.
Yes.
Ma'am, can you please give the comments and introduce our chief guest, Tushar Kar, sir, right now? Abhishek, can we have the slide for sir, and madam can introduce our guest also?
Yes, yes, ma'am.
Rekha ma'am, your comments for the webinar first, and then please with the introduction of Tushar sir.
Okay.
Ma'am, you were audible right now.
Yes, yes,
Yes,
yes,
ma'am.
I'm.
Yes, ma'am.
Today we are having the Public Awareness Committee Fogsi webinar of East Zone. This is episode 11, and Dr. Tushar, I can't see it in the.
Yeah, Abhishek,
Yes,
can we
yes,
have the slide?
Yes.
yes, yes, ma'am. Yeah. It's on the screen, ma'am.
Yes, I would like to welcome Professor Tushar Kar, who is FRCOG, MD, FICOG, MICOG, FICMCH, and Fellowship Laparoscopic Surgery, USA, Professor and Unit Head of Department of Obs-Gynae, SCV Medical College, Cuttack. He has got many awards with FRCOG degree by RCOG London in 22. He is president AOGO, Association of Obstetricians and Gynecologists of Orissa, chairperson ICOG 1920, and vice president Fogsi 2010. Chairperson Fogsi Oncology 2004 and 2009, and national corresponding editor Fogsi Journal 14 and 16. He has been a peer reviewer of International Journal of Obs and Gynae Indian edition, and executive committee member ICOG, executive committee member IAG, organizing secretary IAG, organizing chairperson ICOG National Conference, and faculty and resource personnel in many national and international conferences, contributed many chapters in many textbooks, and published more than 50 articles in national and international journals. So he is well known to everybody, and a very humble and a very nice person. And we would always look up to whatever he is doing and whatever he will be doing in the future. So welcome you, Dr. Tushar, and welcome to this webinar, which is of PSC committee. And but we all are so jointly doing things that it is not only the public awareness, but about everything in gynecology. I almost adore both of you, Tushar, Dr. Tushar and Dr. Kavita Bapat. Everybody is really so knowledgeable, and you have been doing things very properly, in a very good manner. Welcome to this very important webinar series. So give us some input, some blessings from your side to this webinar.
Sir, you're
Monica?
not audible.
Yeah.
Yes.
Rekha ma'am, at the outset, I am much humbled before all of you for nicely introducing me. Rekha ma'am, I am really humbled. At the outset, Jai Jagannath, blessing from the car festival. You know, Jagannath car festival is going on.
Yes.
Yesterday was Bahuda return journey of Lord Jagannath. Today
Yes.
is Sunabas. On this auspicious occasion, you see public awareness committee with all members like Rekha, Monica, and Priyank under leadership of Priyankar are doing this job, great job of webinar, and especially on a very good topic, you know, environment and infertility. As all of us aware that nowadays, because of the change of the climate, change of the environment, everything is being influenced, including infertility. It is told that as a gynecologist, while you are seeing the infertility patient, whether you are an IVF specialist or a general OB/GYN, so any patient comes, first sentence is change of lifestyle. So which includes, out of the change of lifestyle, the first thing includes is environment. Let it be global warming, let it be use of the more pesticides, more chemicals, then more oils, everything now contribute to change in the environment. To add on it, the lifestyle. As you know, the sedentary lifestyle has put a lot of difficulties, or is a lot of obstruction for the fertility to occur. Let it be a male fertility or a female infertility. So to counteract this, so the first thing is that you must have a pure organic thing, organic food, organic life. So that includes the mindset and, you know, the little exercise, no sedentary life, and most important is a spiritual, holistic approach. That is very important in addition to this environment. And holistic approach will perhaps amalgamate with this change in the environmental and leading an organic life, that which favors the fertility process to occur, and which perhaps the God, like our mother, she has given from the beginning the biological process. So it should not be obstructed by inorganic one. This and change, global warming, all these should not affect the fertility. So therefore, I give attention to the holistic approach. And the speakers are very much learned. Perhaps everybody will do their justice up to our satisfaction. And the participating clinicians will be very much benefited with this conference. Thank you very much. Again, I thank Monica for inviting me, Priyankur, and Rekha ma'am, and the entire organizing committee for this event to occur. And best of luck for this event. And let every participant be benefited at the end of the webinar. Thank you very much. In fact, I am on the way to be PG examiner for the RML, Ramon Loya Medical College, now on the airport. So thank you very much. And tomorrow is their exam, postgraduate MS exam. Thank you very much.
Thank you so much, sir, for your blessings and your gracious presence. We wish you all the very best, sir.
Thank you.
We
so
all
much.
are with you. Thank you so much. I would now take privilege in introducing Dr. Arun, sir, who is our guest of honor for this evening. He's a consultant at Apollo Fertility Guwahati and Apollo Hospital at Guwahati. He is also the chairperson of the Northeast IAGE, peer reviewer of Journal of OBGYN India. He is the founder chairperson of the Northeast ISAT, the past president of Dibrugarh OBGYN Society, a senior vice president IMA Assam State, the vice president East Society of Vaginal Surgeons of India. He is also an active Rotarian since 1995. We welcome you, sir, and please bless us with your kind words.
A warm good evening from the Northeast and from my personal side to all of you. I'm aware the Public Awareness Committee has been working very hard and trying to reach out to every nook and corner of the country, and more so to this particular region. We all realize that awareness remains key to the success of every matter, including the health parameters and also the prevention of different diseases. So today, as far as the fertility is concerned, Tushar has already given you an overview how we are affected with our fertility potential by different environmental pollutants. I'm not going to repeat, just to add to that, a very strong component in the female hygiene, the sanitary pads that every ladies are using during their menstrual cycle, has also been tagged in to be one of the very important component of the environmental toxins, because these pads are mostly producing a toxic called dioxin. And today we know what dioxin can cause. We also are aware that WHO has banned this dioxin in 2003 onwards. But gradually, one and all, everything remains related. So the disease that have seen an uphill these days are related to this toxin some way or the other. So making public aware of their fertility, making public aware of their preventive role in attaining good health remains the agenda of a professional organization, and Public Awareness Committee of Fogsi has been ably doing that so perfectly. We are proud that we got the privilege to speak few lines so that we reach out to everyone. And I'm thank you, every one of you, for asking me to join this today's program. And any scientific program really teaches us something new. And today also, I'm sure we'll learn something new. So with blessings from Ma Kamakya and from the state of Assam and the Northeast, I really wish success of the coming CME program. Thank you so much.
Thank you so much, sir. We are honored to have you and Tushar sir and Kavita madam sharing the same platform here with the Public Awareness Committee from the East Zone. Thank you so much for blessing us. We now move forward with the academic session. Dr. Kavita Bernwal is out of station, so she could not join, and Indranil sir is in a surgery. So I would like Rekha ma'am to introduce Kavita Bapat madam.
Dr. Monica, I am also outstation. I would like to show everybody present here the view which I'm getting right now. See.
Oh, very good. Don't worry, don't introduce me. I will the lecture. Just don't worry. Enjoy. Don't worry.
So, you
are at the best of the environment. So enjoy.
Let's start it. Yeah. Can we have the Kavita madam slide, please, Abhishek?
No. Yes.
Kavita Bapat madam.
Let the slide run, and I will make a very fast.
Ma'am, the slide is on the slide is already on the screen.
On the screen, I can't see it. Oh, okay. So, Dr. Bapat, she has been Vice President Fogsi 21-22. Very beautiful soul, a very beautiful person, and very friendly also. She is a doctor at Bapat Hospital, Indore, organizing secretary of AI COG 22, which was beautifully done. And one day hysterectomy specialist, ICOG Vaginal Surgery Certificate Course Center, Jogi, peer reviewer, and initiated registry of primary ovarian insufficiency, editor of Polo Medicine, World Bank records for contribution in medical services, Healthcare Award by Dainik Bhaskar, award winner of Naika Indore and Captain of Industry, Vice President AMPOG, Chairperson Breast Committee Fogsi, Vice President MP Chapter Vaginal Surgeons, and member of Urogynecological Committee, Executive member of ISAR and IAAG, Post Governing Council member ICOG, President Indore Menopause Society. With all these accolades, she is a very accomplished person, and actually the thing is,
Thank
as
you
you
so
accept
much,
her
Rekha.
accomplishment, it is really great that you accepted all your accomplishment and everything in a very good stride. And so, welcome, Dr. Kavita Bapat.
Thank you so much. Allow me to share.
Yeah.
Love you. Enjoy your seat and such a nice place you are. Thank you so much. Thank you so much for introducing me and took out the time. Allow me to share the screen so that I can. Yeah. Thank you.
Ma'am, you
Yeah,
can
my
share.
scene is- Yeah.
Yes,
My
ma'am.
scene is visible. Yeah, it's visible.
Yes, ma'am. Just make it. Yeah. ma'am.
Thank you so much, the Public Awareness Committee, for giving the topic, which is being environmental factors affecting the male and infant women. The most thank you number one is to Monica. She has taken all the efforts to do all these programs, and congratulations to Public Awareness Committee this year, the Priyankur and all. Thank you so much. So being this topic being given to me, the environmental factors, though I'm not an infertility specialist, but I love to talk few points which are very important nowadays, and we find it that the environment has changed. I think our own Tushar Kar sir has spoken in the few lines. He spoke so well about the how it affects the infertility and everything. So we have given the topic, and I am here to talk about. So infertility basically affects millions of people, has an impact on the families and the communities. In every 6 people of the reproductive age worldwide experience the infertility. Now, the point is male infertility. Number one, the problem with ejection of semen, the absence of low level of sperm, and third is the abnormal shape or the morphology and the movement, motility of the sperm. The female abnormalities may be at ovary, maybe at uterus, maybe at fallopian tubes, and maybe at endocrine system. So another important point, the artificial reproductive, this ART, use of ART by infertile couple increasing every year. What we have seen when we were students like me and Dr. Tucharkar, when we were the students, hardly anybody has that much access to do all this type of treatments or anything, or these facilities or nothing was available. And the science was also not that much developed at that time. So in 1950, there were average 5 children per woman worldwide. And there is average 2 children in 2010 by now. And then what we are thinking about. Now, in US, there has been overall long-term decline in the birth and infertility rates that has been attributed to the multiple factors, including advanced education, career opportunities of the women, later marriages, improved access to the contraception, delayed childbearing, and decreased family size. Then these are the epigenetic factors. They are the alteration into the way gene work for, caused by the environmental and the lifestyle factors, could be cumulative across the generations. The chemicals, which are very, very important, we nowadays talk about the plastics. Number one, household medications, they are also chemicals. Then in the food chain and in the air affects the men as well as women. Now, the environmental factors can be a black carbon, forever chemicals like the phthalates have all been found to reach babies in utero. Poor diet, that's another big thing, sedentary lifestyle, which is troublesome, stress, alcohol, drug use, all are the reasons to have the sperm count goes down. Climate change may be negatively impact the male infertility. The heat waves have been shown a damage of the sperm. And 2022 study found that the high ambient temperature leading due to the global warming, number one, working in a hot environment, negatively affect the sperm quality. Now, the air pollution is another important thing, significantly impacts human fertility and sperm quality. Semen quality is the primary predictor of male fertility outcome. And environmental pollution unfavorably affects semen quality by impairing the process, thereby leading to the decreased male fertility. On the female side, increased risk of menstrual cycle dysfunctions and irregular periods, potentially associated with accelerated ovarian aging. Now, the air pollution, common levels of nitrogen oxides are bad. Smoking in raising the risk of miscarriages, and pollution particles have been found into the fetal side of the placenta. The woman exposed to the small particles, that is 20% greater risk of infertility, and the average pollution level of the Chinese couples was 57 microgram per meters cube was found. Now, again, the air pollution is a big troublesome, but certainly the steps of the individual can take to reduce the exposure, such as air filtration system in high pollution location and avoiding exposure to the high traffic. In London, UK, the average about 30 microgram, and studies of dirty air and fertility have used data on sperm quality, perhaps because this is the easier to obtain, with 2017 review concluding air pollution has a negative effect. Now, the pollution particles are known to cause inflammation in the body, damage the eggs and the sperms, and the scientists say another study found to increase the exposure of air pollution associated with a lower number of maturation egg. And we can found, because we all have learned the air quality index during the COVID time, because it was good and better air quality index during the COVID time because of the less pollution on the roads, no cars and everything. But these are the level pollution, and you can see where the pollution is maximum. That's most unhealthy in Uttar Pradesh, Bihar and Rajasthan. They have found it's very high, it's up to 115 to 200. And the states like Andhra Pradesh, Tamil Nadu and Karnataka, they have the least pollution. So that's another big point. So we should talk about and think about. Now it's a matter of survival. How much air pollution is, how can you can live. If there is a 3 hours without shelter, 3 hours without water, 3 days without water and 30 days without food. That's a very, very important, and 3 minutes without air. So that we can see what we have seen during the lockdown period, and we were happy to know, see how the Yamuna used to look like and now how it looks like. Same with air pollution at this India Gate before and after lockdown. And this is another, it's a Los Angeles, California, the same problem. The healthy conditions for the egg cell maturation is important, and the properly generate proteins like a telomerase. This is a very important telomerase and promote the success of embryo development. Now, these early embryo develop successfully through molecule called telomerase, and telomerase made during oocytes, and that's very, very important. Then this protein is affected by the pollution and all those problems, and this which drive the synthesis of new protein support all those things. Now, how environmental things affect the semen count and all? Physically, light, temperature, radiation and weight. Biologically, virus and microorganisms. Behavioral, stress, drug and addiction. And socioeconomic by nutrition, habit and occupation. And most important, chemical, can be natural or a synthetic. Now, the physically, what actually happens? The enzyme required for the production of the sperm are sensitive to heat. Men who frequently use hot tubs, wear tight pants, sit at the desk all the day, stand in front of hot stove, ironing may cause heating testicles and can't make sperms. And testicles should be 4 degrees cooler than the normal body. That's another important point. Weight, as already we have seen so many problems due to weight, the NCDs and all are there. Same with a sperm count. Being overweight, body fat levels that are 10 to 10% are normal, can overload the body with estrogen and throwing off the reproductive cycles. Being underweight, if it's less than 10-15%, below normal can completely shut down, and there is another problem of the reproductive process. Biological virus, HPV is important. Stress, another important, chronic ovulation is there. Then the psychology, there's so many things are there with the stress related in a male as well as female, and decreased sperm count, extreme motility, impotence, and all the points are there. Now, how the oxidative stress works upon? It is a work on polycystic ovarian disease. It again works, it causes abortion. All the ART assisted reproductive techniques are elevated ROS in semen, and in vitro culture related to poor fertility outcomes. Embryopathy, fetal alcohol syndrome, cleft palate is another problem which can happen with the stress. Another hereditary form, moles, unexplained infertility, and the endometriosis and tubal infertility are due to stress can happen. Again, this can lead to sperm DNA damage, number, motility, morphology impairment, and male fertility is the reason. It can be the oxidative stress, maybe due to the high red meat. It's very, very important. And it is because of this, it can process intake. Then low fruits and vegetable intakes that can cause oxidative stress. High temperature that can cause oxidative stress. Again, low physical activity, excessive coffee, high fat diet intake, and stress all leads to these things. Now, socioeconomic, the smoking is another important point. It contains toxin and which can have the bad effect on the male health. And men who smoke are exposed to high levels of the metals like calcium, cadmium, and lead, and that can lead to sperm count can be less. Then these are again linked to the decreased fertility. Sperm morphology is bad, motility is bad, DNA changes, sperm concentration changes, and damaging sperms genetically, imbalancing. And as per studies conducted, the success rates is 22% in the couples who smoke and like that. Now, the chemicals are the endocrine disrupts. Number one, molecules that mimic the body hormones, throw off the vaginal hormone balance of the reproduction. And these are the substances like phthalates, then better known as plasticizers, and these are the problems. And then the pesticides, herbicides, heavy metals, toxic gases, all are the synthetic material, lead to harmful effect on the human fertility. Endocrine disrupting chemicals could be pollution. These are a big list. This is the benzol, dioxins. There is very common. Dioxins is the number one thing now we have seen. Pesticides in general, DDT and the lead are the problem. Then these are the toxins effect and the factors. Effect on male reproductive system. Sperm count goes down, behavioral problem, fertility decreased. And these are the phthalates, organochlorides, pesticides. Lead reduces the male fertility. Carbon disulfide has got the different problem. And these are the scrotal hyperthermia these pesticides can cause. Now, these is the ecotoxicology and environmental safety studies they have done, and they have found out the sperm quality disturbed with all of those. Then these are another big studies elsewhere, and everywhere we are find the air pollution and male fertility, and all these problems are there. Then they have done along many studies, 90 days exposure of air pollution might have a negative impact on the sperm quality. 90 days average concentration of PM 2.5, PM 10 or a CO were negatively associated with the sperm concentration and the motility, and 90 days average concentration of 0.3 was positively associated with the sperm forward motility. Again, average concentration of carbon monoxide was associated with largest reduction in the sperm concentration forward motility. And these are the occupational exposure of the chemicals which can happen to the workers and the families at the risk. Plastic medical consumer products may lead to the dangerous chemicals. Some communities may suffer from the disproportionately from the chemical contamination. And these are the environmental threats. They cause the female infertility, tubal factors 36%, ovulative factors 33%, endometriosis 6%, and unknown is there. So these are the problem with the environmental, and with the car exhaust fumes, smoking, obesity, all leads to these problems. So in future, additional research targeting lifestyle factors that impact fertility are urgently needed. Sperm test should be performed at early age to inform the man that their fertility potential and allow them to adopt lifestyle changes to abort the fertility crisis and occupational hazards. And we should know about it, and they should know that what they can change and what they can be done. And again, men at high risk of fertility professions are not informed of the hazards of their occupation and their reproductive health until it's too late. That's the biggest problem. And in conclusion, we can say, number one, avoid smoke, avoid use of chemicals, any pesticides, avoid use of makeup, hairsprays, coloring products, nail polish, own body to and not damage as media says. Avoid use strong chemicals, glues, paints, nail polish, remover, floor, and a carpet cleaner. Avoid all the unhealthy food, hot food, plastic containers, even on the frozen dinners. So eat deep water fish, avoid swordfish, tuna and shark, all farm-raised fish. In general, substitutes natural products or synthetic products whenever possible. Be organic, and organic. Eat fresh, organic products, meat and milk-free, from RBGH. This is another important point. Buy products at a local farmer market and join buying club. Use fewer processed pre-packaged foods, avoid canned food, avoid products hydrogenated partially, and there are more important. Avoid staying in places that smell of chemicals. Do not give young children soft plastic toys, since this leads the potential endocrine disrupting. And a job is another important thing. With job, the men are doing the heavy lifting, working in a hot concentration is another important. So another take works passage, promoting healthy behaviors, help to maintain and preserve the fertility, promoting prevention and treatment of the medical that threaten the fertility. Then reducing the exposure to environmental, occupational, infectious, and iatrogenic agents that can threaten the fertility. Thank you so much for the patient listening and giving me the chance today to speak into the platform of Public Awareness Committee. Thank you so much.
Thank you so much, ma'am, for a crisp message. Rekha, ma'am, your valuable comments, please.
Yes. The only thing I can remember is be organic, organic, organic. So
Yeah.
any form of toxic agents in your life, you have to just throw it away, like smoking and like any cosmetics that you're using, having most of these things have some lead compounds and all the types of things, masks and everything that you put on, these get absorbed through the skin, and these everything affects the fertility. It affects the general health too.
Thank you, Monica. Thank you so much. Can I leave? One more webinar.
Thank you, ma'am. Thank you.
Yeah,
Yes, ma'am.
Thank you so much for
Wishing you all the very best, ma'am.
Thank you so much. Given me the
Yes,
chance today.
thank
Thank you so much. Nice to see Monica
Thank you.
Kumari and Kanchan over there. Thank you so much. Thank you so much.
Thank you, ma'am.
Bye.
Thank you so much
Bye,
for
Rekha.
accepting our invitation. Yes, ma'am.
Thank you.
Thank you, Rekha, ma'am, for sharing this session. We now move forward to the next session.
So Monica,
our chairperson.
I'm also
Yes, ma'am.
leave. Can I leave also,
Sure, ma'am.
Monica?
Sure, ma'am. Thank you so much, ma'am. I welcome Dr. Nivedita Datta, ma'am, as the chairperson for the second talk. Can we have the slide, Abhishek? Yeah. Ma'am is a consultant gynecologist and obstetrician, and she's currently the president of Bokaro OBGYN Society. She is the East Zone Coordinator for State Motherhood Committee. She's a Manyata Coordinator for Jharkhand. She also is a palliative care specialist and the secretary of an NGO called as Koshish, a rural-based center providing holistic care. We welcome you, ma'am.
A very good evening to all those present, and a special thanks to Monica as well as Public Awareness Committee for giving me this scope for being with you all today and introducing a person who is, I think, a person of great renown and a person who's doing a fantastic work in the field of infertility, Dr. Sujata Kaur. Dr. Sujata Kaur has could I have this thing? Dr. Sujata Kaur is a practicing gynecological endoscopist with and who's doing ART for the last 27 years. She has the privilege of being the first person who has the first IVF baby in the whole of Orissa, the first TISA, the first frozen embryo, and laser hatch babies of Orissa. So you can imagine her field of expertise and the amount of knowledge she has in this field of IVF. She has 15 original publications related to PCOS and male fertility in PubMed. She's written many chapters for books. She is at present the Honorary General Secretary of ISAR India, Executive Member of IAGE, ISSRF, PCOS Society, and FPS Society of India. She has, from her graduation days to her days while she's working, she has been an immense support to the fertility, to the field of fertility in India. I will give you all Dr. Sujata Kaur.
Thank you, ma'am, for her kind introduction. Ma'am has sent a recorded talk because she will not be able to join in as she's traveling to X-ray. Abhishek, can we have ma'am's talk, please?
Hello and greetings from Bhubaneswar. Thank you so much for having me as a speaker in this webinar. My topic today is how to improve the success rate of IUI. Now, IUI is a procedure that we perform very commonly. However, there are lots of controversies regarding its efficacy. There is a wide range of variation when you look at what are the chances of success with IUI and what are the chances of a live birth rate. And we do not have very clear-cut evidence-based infertility data regarding IUI because the indications and the patient populations as published in various studies are very, very variable, and studies have reported from 0 to 26% pregnancy rates following IUI. But then it is every gynecologist doing IUI. The aim is always how to improve the chances of success before you take the option of taking the patient for ART. So I would start by saying that improving IUI success stands on 4 pillars. The first and most important is patient selection, perfect monitoring and timing of IUI. The progressive total motile sperm count is a totally independent variable in deciding IUI success. And finally, IUI setup. Patient selection, I would say that contraindications of IUI are more important to see and note rather than the indications. So mostly the most common and the best outcomes would be found in anovulatory infertility, grade 1, grade 2 endometriosis, unexplained endometriosis, rare causes like anatomical issues of vaginismus, tight introitus, or a imperforate, or a hymen, tight hymen, similar. Non-obstructive azoospermia, wherein you're doing donor insemination, ejaculatory and sexual dysfunction, mild to moderate oligoastenospermia, cases of retrograde ejaculation, and if there are seminal volume and liquefaction defects. So choosing the patient is the first important thing. Whom not to choose is even more important. Perfect timing and monitoring the ovulation again stands on 3 pillars. First is, what are the ovulation induction techniques we employ? How we follow up and do the follicular imaging, and how we perfectly time the IUI. Ovarian stimulation protocols will depend on the patient profile, the indication, the drug cost availability, and the patient response. What we want actually is an optimal ovarian response for IUI would be maximum 1 to 2 follicles at maturity around 18 to 19 mm. A good serum E2, although we don't do that practically, endometrium, which is trilaminar and at least more than 7 to 8 millimeters. IUI and ovarian stimulation is also to be decided very carefully, because we don't want hypo-response, or we do not want multiple pregnancies or multiple ovarian follicles. So IUI, no stimulation may be thought of when there is simple male factor, only male factor. Clomiphene and letrozole are equally effective. Gonadotropin with low dose in cases of chronic anovulation of PCOS may be chosen. Chronic low dose step-up protocols. Recombinant versus urinary are similar results. And addition of antagonist or agonist has no advantage, although I will be talking about antagonist in IUI a little later. Monitoring typically we do with the transvaginal sonography, because in our setup, in Indian setup, that appears to be the most effective, simple, cost effective at least, and doable. But then one can do LH surge or serum E2 levels, a biochemical follow-up. When we do a transvaginal, we should start from early. One can also consider doing a day 2 baseline scan, and then start at least from day 7, day 8 of menses, and then look at the follow the number and size of follicles and the pattern and thickness of the endometrium. There is also a role of employing Doppler, follicular Doppler, and other blood flow parameters in trying to monitor, although it's not mandatory. The basic 2D scans will be enough for majority of them, but then follicular Doppler may be employed apart from size of the follicle to decide whether the follicle is mature or not. Typically, a mature follicle shows vascularity in at least 3/4 of the follicular circumference. The PSV would be around 10 centimeters per second or more. At this time, the LH surge starts. We know that has been correlated biochemically, and this would be the right time to give a HCG trigger. Rising PSV and a steady low RI suggests that the follicle is close to rupture. Decreasing PSV and rising RI suggests the follicle is likely to become luteinized unruptured follicle. Fertilization of a follicle with PSV of less than 10 may result in an embryo with chromosomal abnormality. There are some studies which have reported this. Perivascular vascularization, if you need to note, this would be considered as grade 1, grade 2 maybe around 1/4, grade 3 would be around 25 to 50%, and finally grade 4, which is supposed to be the good and the most optimal, would be around more than 50% of the follicle. Does follicular size and maturity differ based on what ovulation induction drug we have used? Yes, when you're using a natural cycle, anywhere between 18 to 30 millimeters can be a mature follicle. When you're using a clomiphene citrate, 18 to 26 millimeters. Gonadotrophin cycles, typically the follicles are mature a little earlier, which is around 14 to 16 mm. And in an agonist cycle, we would wait for at least a 17 or a 18 millimeters. Another sign of an impending rupture, if you're using a 3D scan, is to look for cumulus in a follicle, a mature ripe follicle, and you know that, okay, this is a nice mature follicle. And what about the endometrium? Of course, there is a very close role in trying to monitor endometrium to time your IUI. These are a couple of images of various types of endometrium that we come across. Ill-defined, a thin endometrium, a nice triple line pre-ovulatory endometrium, a hyperechoic or isoechoic endometrium. That may be, of course, sometimes because of the imaging issue, you know, from which direction you're imaging. Sometimes you get just the coronal view of the endometrial cavity, and that gives you this kind of an image. So it's very important, and we know that the thickness less than 7 millimeters is unfavorable for implantation in any kind of conception. Endometrial characteristics, grade C is considered favorable. And type A or B is, associated with poor no pregnancy. What about looking at the uterine artery flow? And when should we start looking for these Doppler studies, Doppler flows? Ovarian start from day 2, day 7, day 9, and then keep following up. Anechoic collection, we should look at if there is any collection in the endometrial cavity and follow it up. If it is immediate post-menses, day 7, day 8, we can follow up. Mostly it disappears. Whether it's thick echogenic, and a thin endometrium is considered post-menses if it is less than 3 millimeters. Chances of pregnancy is considered to be almost 0 when the uterine artery PI is more than 3 and RI is less than 0.9 on the day of NCG. So there's a role of that, and there is an Applebaum uterine artery, uterine scoring system, which has multiple parameters that is taken into account: endometrial thickness, layering, endometrial contractions movement. This is a very extensive, blood flow through the various zones. We do not generally employ it for an IUI cycle, but it's good to know about the various scoring systems so that you are comfortable, and when one parameter doesn't match your requirement, you can look for other parameters even when you are employing a natural a timed intercourse or a IUI cycle. What is the importance of power Doppler in the subendometrial blood flow? So poor chances if you find if you look at the power Doppler and you find the blood flow in the various zones, and then also calculate the VI, FI, and BFI, which is automatically calculated by your scan machine if you have a vocal software. And it has been shown that there is no pregnancy if vascularity index is less than 1, if the FI is less than 31, and the vascularity flow index is less than 0.5. 0.25. This I have put only for the sake of completion. Practically for an IUI cycle, we will probably not be using these parameters. Endometrial volume is another very good indicator of how good and how receptive your endometrium is. Typically, it has been considered that most pregnancies would occur between a volume of 2 to 13 ml, and it is important to calculate that when you have uterine abnormalities like in adenomyosis or a previous situation where you've done an adhesiolysis for Asherman's and all that, in those specific cases, you might want to look at the uterine volume. So is 3D ultrasound better than 2D? I would say overall, no, they balance out. And typically you would not need them, and certainly no guidelines tell you to use them on a regular basis. So best part is that it facilitates non-invasive evaluation of endometrium, identifies some organic problems that can be negatively correlated. Implantation negatively correlates with implantation, but it allows prompt integrated evaluation of all known receptivity markers by measuring the morphology, the thickness, the texture, the pattern, the volume, endometrium and subendometrial blood flows. So this is some other parameters that you can look for if you're looking at your endometrial vascularization with 3D, 2D, and even power Doppler or color Doppler. Now, let us move over and see if there's a role of GnRH antagonist in IUI cycle. We do hear sometimes consultants use an antagonist cycle, but then we have very less evidence. And typically in IUIs, you would not need. Maybe the maximum benefits I have pointed out could be some. It controls the LH surge and times the ovulation better. So you will have a better proper synchronization if you're doing a single IUI. And if you want to, tide over a time that you're not available, like over a weekend or something like that, maybe you could do that. In severe polycystic ovarian syndrome or women with PCO morphology, with LH hypersecretion, it can be used to suppress LH in stimulated cycle. You could do that. Allows stimulation to continue till dominance is achieved on the desire site when there is, one patent tube. These are some theoretical causes where you can use an antagonist cycle. Allows trigger to be given with GnRH agonist instead of HCG in the event of a hyperstimulation. And of course, I think the single most important thing would be how to time your IUI. So you can really fine tune by giving an antagonist at the right time. Next comes the timing. I think that's pretty standard. So let me not go into it. If you're doing a double IUI, which really doesn't have much benefit, you could time it first one around within 24 hours, and then the second one around 36 hours. Or if you want a single one, it should be probably timed around 38-40 hours post HCG. That would be a good choice. The technique is also important, should be done properly, nicely, and atraumatically, so, and also as much possible as to prevent infection, one should try and do that. So as much possible care should be taken. There is a role of intracervical insemination in a couple of cases also. In fact, I do that very often, that I do the IUI, and as I start withdrawing, I do leave some in the endocervical region, because we know that the sperms can be stored in the cervical crypts, and then that can act as a reservoir of sperms and then continue to perfuse and infuse through the endometrial cavity and reach the fallopian tubes, over a period of couple of hours, maybe 24-36 hours. So that possibility one can keep in mind. Now, next important thing, like I said, told you, one of the most important pillars of success in IUI belongs to the seminal fluid parameters, and the number of progressive total motile count is an independent deciding factor for chances of success with IUI. So the purpose is, of course, to achieve the largest number of morphologically normal motile sperms in a small volume of physiologically cultured media free from debris. That is our purpose of preparing the seminal fluid. And PTMS count is an independent predictor of success. We should have at least 10 million total motile sperms, which is considered significant. Sperm concentration 1 million, total insemination. The concentration around 10 million, like I said. Morphology, if you use strict criteria of Kruger's, it should be at least 4%. 4 to 9% is good. Sperm DNA fragmentation, we have no data. And we also know now, with this, based on this Cochrane analysis of 2019, there is no difference between different preparation techniques using IUI. And finally, the lab setup. IUI is a cheap, simple, effective, non-invasive method to improve the chances of pregnancy for your infertile couple. It is, of course, used to treat only a certain group of subfertile couples. And although IUI can be performed outside a specialist unit, but now we know that we have level 1, level 2, level 3 units, and we need to follow those criteria. And based on that, who can do IUI, etc., has to be decided. But then, a best setting would be a clinic with IVF facilities, because we know that they would have a perfect lab, and they will have possibility of switching over, and they would have a better expertise with ovarian ovulation induction, etc., etc. Finally, predictive factors for intrauterine insemination outcome. I thought I will put this as a concluding slide. So this was a publication of 2020 about the factors that decide IUI success. So total motile count more than 5 million. High sperm DNA fragmentation, although that does not consistently, affect pregnancy rates in IUI. Advancing maternal and paternal age negatively impacts. Paternal obesity and maternal BMI negatively impacts. Letrozole clomiphene results are almost the same. Ovulatory, most effective, IUI is most effective in ovulatory dysfunction and unexplained infertility, grade 1, grade 2 endometriosis. And first 4 cycles would be the best for having a successful outcome. So in the era of IVF and ICSI, IUI would probably be considered in women who are less than 40 or less than 35 in our scenario, have both normal tubes, have normal or mildly reduced male factor, a short duration of infertility, maximum 4 cycles, and gonadotrophin stimulation also may be attempted, or a combination, which would be the best choice. So if I have to wind up my talk with 10 points to improve IUI success, it would be proper patient selection, sensible protocols to stimulate the ovarian stimulation, perfect monitoring for ovulation, do your own ultrasounds, time the IUI perfectly. Technique is important. Vaginal misoprostol, again, that would be create a lot of debate, but may be considered in difficult cases. 10 minutes of bed rest, again, plus and minus, but advising an intercourse 18 to 24 hours around IUI is considered to be beneficial. Pay attention to disposables and media, cultivate a good, intelligent lab technician, embryologist, invest in a proper lab setup, and consider a proper luteal support. Thank you so much, and thanks once again for having me in this meeting. Thank you.
Nivedita ma'am.
Thanks. I think that was superb. No wonder she's called an expert in infertility. Because IUI is something I think most of us are doing. We should know where we can do the IUI, and how to maximize the outcomes is something which she has given so simply. Dr. Sujata has given it so simply, to the point, and it's very, very important that all these protocols should be followed, so that whenever we do an intervention, we should try to give the best results for that intervention. Thanks a lot, Dr. Sujata, and I think I hand it back to Dr. Monica for continuing the rest of the proceedings.
Thank you so much, ma'am. Thank you, Sujata ma'am, for accepting our invitation, and thank you, Nivedita ma'am, for chairing this session. I now move forward for the next academic session, which is a panel discussion moderated by none other than Alka Pandey madam and Shamila madam. But before that, I would like Alka ma'am to please announce the results for our competition. Abhishek, can we have the PPT, please? Alka ma'am, what were your views while judging this competition?
Yes, can you show the results, please?
Yes, ma'am.
ma'am. Yes, ma'am.
Ma'am, on the screen.
Yes. This is the second prize, I think.
Yes, ma'am.
Dr. Suvarna Bhopale, Society Thrissur, OBGYN Society, has received the second prize and they have done a wonderful job. So, congratulations to them. And the first is to Dr. Asha Nikte, Society. Patna OBGY Society. Individual was Asha Nikte and the society was Patna OBGY Society. Congratulations.
Hello?
Monica.
Ma'am. Ma'am, what were your opinions
Congratulations
regarding...
to all of them. They have done a wonderful job, all of them. They had made wonderful collages. They have done wonderful plantation. Really, it was very heartening to see all the efforts taken by them. All of them were very good.
Thank
Difficult
you
to
so
judge.
much, ma'am. Thank you so much for accepting our invitation as a judge for the competition. I know it is very tough, but we keep on troubling you every time, ma'am.
Okay.
Yeah. Thank you, ma'am. We now move forward with this panel discussion. Can we have the slides, please, Abhishek, for the introduction?
Yes, ma'am.
Our expert for this panel is Dr. Kanchan Murarka, ma'am. We first introduce our moderator, Dr. Alka Pandey, madam. She is the Vice President in charge of the Public Awareness Committee, Fogsi. Abhishek, please, the slide.
Yes, yes, ma'am.
She is also the Associate Professor at Patna Medical College and the member of the Governing Council member ICOG for the year 21-22. She has been the chairperson of the Practical Experiment Committee, the National Corresponding Editor, and the President of the Patna Society for the year 12 to 14. She has been the Joint Organizing Secretary for the 57th AICOG and the Organizing Chairperson for the Boxcon Bengal OBGY Society Conference in 2014. We welcome you, ma'am, as a moderator for this panel discussion. Our next moderator is Chandana. Yes, ma'am. She is currently the Vice President-elect Fogsi for the year 2024. She is has been the chairperson of the Clinical Research Committee Fogsi. She has also been the ICOG Governing Council member for the year 21-22 and currently till the next year. She's the National Coordinator for UNICEF Fogsi TCA, the National Coordinator for MEDA Fogsi TG Program, the National Coordinator for ISAR Gurukul 22. She's also a WHO MD India member and the past secretary of Trichy OBGY Society. She's also the joint secretary for Gestrosis India Association. We welcome you, ma'am, and thank you for accepting our invitation.
Yeah, thank you, Monica.
Our expert, Dr. Kanchan, ma'am, is a senior IVF consultant at IHR Guwahati. She was the former consultant at the Marwari Hospital and Research Center. She has various publications in national and international journals to her credit, and she is the treasurer of the Northeast ISAR Society. We welcome you, ma'am. Our panelists for today are Dr. Nivedita Mishra, ma'am. With the slide, please.
Ma'am, on the screen.
Yeah. She holds fellowship in infertility from 3 different institutes. She has certifications in laparoscopy and hysteroscopy. She has Fogsi certification in ultrasound and colposcopy from the year 2016. She is also the clinical head at Nova Fertility Center, Ranchi since 2019, and she has several publications to her credit. We welcome you, ma'am. The next slide, please, Abhishek. Dr. Yamini Agarwal, ma'am, has a fellowship in reproductive medicine and is a consultant at Nova IVF Fertility, Siliguri. We welcome you, ma'am. Dr. Gayatri is a laparoscopic surgeon and a fertility consultant at OSS Fertility, Bhubaneswar. She has various publications in national and international journals, as well as she has authored many chapters in the various textbooks. We welcome you, ma'am. Our next panelist is Dr. Simi Kumari. She is an infertility consultant, oncologist, and a cosmetic gynecologist. She is once a Fogsi certified advanced IVF trainee. She has a diploma in reconstructive and cosmetic gynecology and is working as a chief fertility consultant at Holistic Fertility Care. She has received the Bihar Women's Achievers Award for the year 21 from the Honorable State Minister, as well as the Bihar Vibhuti Award from Bihar Swasthya Shiksha Parishad in the year 22. We welcome you, ma'am. Our next panelist is Dr. Monica Kumari. She is the Chief IVF Consultant at Srishti Clinic, Kolkata, and she's also a visiting consultant at AMRI and Fortis Hospitals. She has a diploma in ART from Germany, and she has a master's certification in ECOG training, ultrasound training, and she has been a faculty at various state and national conferences. We welcome you, ma'am. Our next panelist is Dr. Sakshi Singh. She's a director of Sumit Fertility Clinic, Ranchi. She holds a fellowship in reproductive endoscopy from the Johns Hopkins Institute. She has been the winner of the ESR quiz in 2014, and she has presented various papers in ESR in 2014 and 15, and she has done national and state presentations. We welcome you, ma'am. Our next panelist is Dr. Indu Shivan, madam. She holds a certificate course in obstetric ultrasound as well as laparoscopic surgery. She has done an advanced course in IVF and ART from the Boston IVF Center, USA. She also has a Fogsi Training Center on Advanced Infertility at Rich IVF, New Delhi. She's a life member of various academic associations and the past president of Jamshedpur OBGY Society. We welcome you, ma'am. Over to you, Alka ma'am and Shamila madam.
Yes. Can you share the slides, please?
Yes,
I'm sharing.
yes, ma'am. Just in a minute.
I'm sharing.
No, I'm sharing this.
Abhishek, you keep it ready. Let Shamila madam share the slide.
Okay.
In case if there is a problem,
Okay.
then you share.
Okay, ma'am. No issues.
I'm extremely happy to have Dr. Alka Madam as the co-moderator and a special person, Dr. Kanchan, as expert. It's always a happy moment to see you, Kanchan, in any program. Panelists, I think Dr. Nivedita has joined, Dr. Yamini, Dr. Gayatri, Dr. Simi, Dr. Monica, Dr. Sakshi, Dr. Julie, and Dr. Indu Chauhan. I think I did not see Dr. Julie.
Julie was not there.
Okay, Julie is not there. So Dr. Nivedita Mishra is there.
Yes.
Yeah.
Yeah,
Dr.
hi. Good evening,
Yeah,
madam.
hi. Dr. Yamini.
Yes, ma'am.
Yes, good
Yeah,
evening, ma'am.
Yeah, Dr. Hi. Dr.
Yes,
Gayatri.
ma'am. I'm there. Good evening.
Dr.
Good
Simi
evening,
is-
everyone.
Good evening. Dr.
Yes,
Simi.
ma'am. Yes,
Dr.
ma'am.
Yeah, thank you. Dr. Monica. Dr. Monica is there? I think
No.
she's not. Oh,
No.
Dr. Sakshi.
He is there. She is there.
Dr. Julie is not there. Dr. Indu is there. Okay. So
Yeah.
we've got 1, 2, 3, 4, 5, 6 panelists
Two
and an
people are
expert.
missing.
Yes, ma'am. Yes. So, ma'am, can you take the case scenario? Dr. Alka, ma'am.
So she was a woman named Mrs. V, age 33 years and having regular menstrual cycles. She was married since 3 years and there was no history of sexual dysfunction. Her BMI was 31 and vitals were normal. Thyroid profile was normal. Ultrasound pelvis showed uterus and ovaries, which appeared normal. The antral follicle count was 3+4. Then semen analysis was 86 million per ml and 70% motile.
So this is like, I think I'll ask Dr. Nivedita Mishra. Dr.
Yes,
Nivedita
ma'am.
Mishra, she's
Yeah.
33 years old, regular cycles, married since
Yeah.
3 years, no sexual
Mhm.
dysfunction, BMI is little higher, vitals
Yeah.
normal, thyroid function normal, ultrasound looks okay, little poor reserve, but 3+4 is quite okay. Semen analysis fine. Tubes were checked actually, and that was also fine. So this looked like a case of unexplained infertility. Like how many cases of unexplained infertility you see in your OP?
30% of cases can be of unexplained, ma'am.
After you investigate them more, do you get a diagnosis, or it's like 30% is totally unexplained?
No. After when we investigate, it can be come down to 10%. Like if we go ahead with like DFI or for the male pattern, even if it is normal, sometimes teratogespermia, even if it is 1%, then DNA fragmentation index we conclude for men. For females, AMH is equally important, and as we can see, this woman is having a obese BMI. So it can be one of the reason. And 3% are laparoscopy and hysteroscopy. Often the grade 1 and grade 2 endometriosis
Now,
can
what
be
are the basic tests you will say and then say it's unexplained infertility? What all you think is definitely necessary?
Definitely, I will go for AMH. Yeah, I will go for AMH and sperm parameter, which will include the like here. It is not. There's no comment on morphology of the sperm, so I feel it is equally important.
But basic, all this is needed of a patent fallopian tube, documentation of ovulation, and you need an semen analysis with adequate number of motilized sperms.
Yeah, ovulation we need to study.
Yes, ma'am. Alka, ma'am.
No.
So, what are the potential contributors to subfertility? See, Dr. Roy Haumburg has said very clearly, like all the subtle things can be there. As you said, AMH, DNA fragmentation test, all that is like the sperm parameters. It appears normal, but there may be something intrinsic just causing a problem. So you want to pick up somewhere. So you try with the DFI.
With the DFI, we can pick any subtle abnormalities in male. At the same time,
will it change your treatment if you do a DNA fragmentation test for a person of 3 years infertility?
Ma'am, if a patient is having any sperm parameters, like if he is, I need the history also regarding any kind of substance abuse, or if he is exposed to the condition.
Nothing.
But the sperm count is normal in this case, no?
Everything is
ma'am,
normal.
There is no, it is normal. Only the comment is not there on that morphology of the sperm.
Yeah, morphology is not mentioned.
Yeah.
So these are the potential contributors which Dr. Roy Haumburg mentions. And when you want to say that it's unexplained infertility, you will need to document that she's ovulated. That has to be very clear in your history. And tubal patency test, as you said, you said you'll go for a laparoscopy.
Yeah, ma'am, if tubal patency is okay, and if we cannot find a cause for infertility, then we will go for the next step to see if there is any endometriosis or any kind of adhesion that may affect the tubercle function. Not about the anatomical patency I'm talking about if there is grade 1 endometriosis, it may affect the tubal wall, or if the anatomy of the tube and ovary are affected. Like we see in endometriosis, sometimes it may happen.
Yeah, perfect. So tubal patency, which whatever you think is correct for that particular individualized there. Semen analysis, you said, should be perfect. Morphology should be there. And you need a saline infusion sonography sometimes to pick up the subtle problems in the endometrial cavity. Ovarian reserve testing, as you said, AMH is definitely needed before you say it's unexplained infertility. Laparoscopy in symptomatic women, it's not for all, but when you want to do it, now diagnostic laparoscopy has been taken off the picture of managing infertility. It should be therapeutic. You suspect something, you should go with an idea of finding out like what's wrong. Just for patency,
that can come from the history also. If there is a pain in the history, symptoms during periods, dyspareunia, dysmenorrhea can be there.
Because you cannot go for an invasive testing without an indication there. So you can go for IVF straight away instead of going through all that, which are all quite invasive. So you think before you say that laparoscopy can be done for infertility evaluation. Hysteroscopy should be done if there's a known uterine anomaly or you think there's a pathology which you need to identify. So this is the WHO.
Yes, ma'am. I was just telling you, if in saline infusion sonography, if there is no defect, then hysteroscopy is
not needed at all. Then analysis that we have already talked about that. So can I ask Dr. Yamini, what is not necessary to say it's unexplained? We went through a battery of tests now, but what do you think we should not do to say that it's unexplained? Dr. Yamini?
Ma'am, like it's been discussed, like laparoscopy is not the first line of diagnosis, the investigation which should be done. And similar way in the previously, we used to do post-coital test and all those things. And even the DNA fragmentation is not required at the first go. And for initially, we used to take endometrial biopsy and all those things are also not needed to know their luteal phase defects. So the basic test, what is needed is to know the ovulation, to know the tubal patency and the sperm parameters. These are the basic things what we need to know before labeling the patient as unexplained infertility.
Perfect.
Very good.
And inclusion in unexplained cases, see, unexplained, maybe we cannot find out is a cervical factor, and we said we don't have, and we can't do a PCT also, it doesn't help at all. Luteal phase defects. Mild endometriosis is not a reason for infertility many times. It's like long period of infertility, and many have those spots there. Ideations also have not been proved to the reason to be infertile. So occult causes, this we have talked about that, but basically they say there's an abnormality in the gamete or there's an abnormality in implantation. There is no valid test available at this point of time to tell us that this is the reason that the patient is not considered, and that's why there's such a big chunk in unexplained infertility of almost 30%. So these are the occult causes, and they say suppose there's a problem in the zona pellucida and that interferes with sperm penetration and also cause a fertilization failure. It can cause an early embryopathy, can cause an implantation failure, and can cause recurring non-random genetic defects in the embryo or trophectoderm. And that same thing in the occult cause can be in the endometrium, which can be in the receptivity, and that can interfere with apposition, adhesion, attachment, or invasion of the embryo, and that will lead to implantation failure. And we'll not even know what's happening and why she's recurrently not becoming pregnant in spite of the best treatment given. These are the factors which affect the successful treatment: age, duration of infertility, mild oligospermia, and endometriosis. So, Dr. Gayatri, can I ask, like, suppose you want to give expectant management, how long do you give in your practice? And for whom do you give? What are the indications?
So expectant management, because if a couple has already come to me after trying for 1 year of normal sexual intercourse, I would like to then maybe go ahead with the next line of treatment, because for a couple who is less than 35 years, a female partner, and she has tried for 1 year and more than 35 years, if they tried for 6 months, then I would not.
No, I'm asking for this patient, Gayatri. She's 3 years infertility, and we think it's unexplained. So, how long will you wait, or will you straight away move into treatment? I'm asking.
No, ma'am. Then, because she has tried for 3 years and infertility, then I would like to straight away go ahead with at least 3 to 4 cycles of IUI. And so I counsel
her. You will not ask her to go for
IUI
expectant management. You'll ask her to straight away go for treatment.
Yes,
right?
ma'am. I would not allow her.
Suppose she comes at age 23 with 3 years of infertility, what will you do?
Yes, ma'am. Still then, even if she is less than 35, she has tried 3 years is a like 3 years she has tried. So I would definitely like to now go it with the next level of management with IUI. I would not like to go ahead with expectant management.
Yeah, perfect. So, because if you ask her to wait, the fecundability in an unexplained infertility is only 2 to 4%. So asking her to wait for another year is not going to work. And particularly when she's older and she's almost like 3 years infertility, as you said, it's not worthwhile asking her to wait again. It's better to you move on to whatever treatment you think will be better for her, because for a normal couple, the fecundability is 20 to 25%. But if she's got a diagnosis of unexplained infertility, it's only 2 to 4%. And there was one prediction model which was brought out by Hunault for unexplained infertility. And in this, he incorporated certain factors. That is the lady's age, the duration of infertility in her, whether it's primary or secondary infertility, and also the sperm variables to predict the possibility of an unnecessary. That is, if you want to wait on a patient, then you take out all these criteria. And the referral by a general practitioner or gynecologist also matters, because if she's referred from a general practitioner, the chance of pregnancy is more. But if she's referred by a gynecologist and she comes as a third referral to you, the chance of treatment will be much better than asking her to wait. So the parameters which he took, the age and the duration of infertility, he said will definitely have an adverse effect on fecundity. Secondary infertility patients will have a much increased chance of having pregnancy when they go for expectant management. And suppose the sperm motility is good, if there's almost 10% increased motility, that person will have an increased chance of having a pregnancy by expectant management. There is almost 8% increase. And suppose you've done a PCT, they say there's a higher chance of having a pregnancy if you have a normal PCT. And if he's referred by a family doctor, the chance is much better. But a tertiary referral from another gynecologist, the chance are much lesser. These are the prognostic factors he took, and this is the way he computed that. And the prediction for expectant was, if the chances are low in that prognostication, it's below 20%, do not ask her to wait. It's better if you go for some form of treatment. If it is more than 40%, he says you can wait, because almost there's a 50% chance of success. And the patient should be advised that there's no ART with an equal chance. They can't think that they jump into IVF and ICSI, they will conceive. There's still a problem even with IVF and conceive. The results are not worthwhile in unexplained infertility. Can I ask Kanchan her thoughts on this? Kanchan?
Hello, ma'am. It's always very nice to see you, ma'am. I would like to thank the committee to have me here. So, ma'am, I think all the valid points have been covered. How to diagnose an unexplained infertility has been elaborated very nicely. And what I feel, ma'am, that the age, the duration of infertility is actually the most important point which we should consider when we are seeing a couple with a unexplained infertility. So if the duration of infertility is less and the age is also less, and of course we can give her expected management. But if again, like already Dr. Gayatri has told, that if the couple is more than 35 and 6 months and less than 35 and 1 year of infertility, we should go ahead with some kind of treatment. So first we can go ahead with IUI, try for 3 to 4 cycles. If other all parameters are okay, then we can try IUI. If the patient is not conceiving, then we can straight away go ahead with IVF.
Do all the other panelists accept what Kanchan is saying, that more than 35 and 6 months straight away treatment, less than 35 and more than 1 year? Both Gayatri and Kanchan said the same thing. Anybody would like to disagree? Because I want a controversy here. At least discuss. Alka madam, what do you think?
Yeah. No, I agree with her, because if the age is 35 and marriage is of 6 months duration, she should have aggressive treatment.
Okay. What about other people? Simi, Monica, can you say what is your opinion on that? Monica's joined. Monica, you're not audible.
Dr. Monica Kumari, please unmute yourself.
If anybody wants to disagree, you give your point. If you want to agree with Alka madam, it is fine. Oh no, she's not audible at all. Okay. Dr. Sakshi is there? Sakshi, what is your point in this? What is your input for this? Sakshi?
She is also there.
Sakshi ma'am is also there, but she is not joined with the audio.
Oh, okay.
Madam Indu Chauhan.
Dr. Indu?
Yeah. Good evening, everyone. I fully agree with all panelists.
Nobody is disagreeing. So everybody is
and rather, I now feel that after COVID, what personal experience says that even the ovarian reserve is declining even earlier ages. So rather we should start doing this 35 to 32. That's what is my, this thing, take on this thing.
And
35 is still very late in Indian population.
No, Gayatri came out to the point that even if she's 23 years old and has come with 3 years of infertility, it's better if you go for treatment in our country. I don't think it's worthwhile asking them to wait for 1 month, because 3 years gone and such a young person is not conceiving. That means she needs some form of treatment. Otherwise, she's not going to conceive. Perfect. So what are the treatments offered? See, these are the treatments which are being offered. I would like your opinion on this. It is usually IUI, which Gayatri said. Will you do with oral medications and then go for gonadotropins and then we should go for IVF? Simi, what are your thoughts on that? Simi? She's there?
I would like to. Yes, ma'am. Yes, ma'am. Yes.
You're named as Tavia. Okay. I was thinking. Okay, yes.
It's me. Ma'am, actually, she's 33 and married for 3 years. And as by the panelists, we just discussed that age matters. Like as the age advances, the quality and the quantity.
No, we have decided for treatment. We are just asking your opinion. What is your treatment you're going to give?
I would see her file whether she has approved somewhere else or not. If she's coming,
she's not gone anywhere. She's fresh.
Then I would like to go with the lateral induction followed by the gonadotropin, and accordingly, if she fails with all those, with the 3 to 4 cycles.
No. Let me get it right. Letrozole with IUI.
Yes.
Or gonadotropin with IUI, or combination.
First, letrozole with IUI.
Letrozole with IUI. Okay. Dr. Monica, what letrozole with IUI, gonadotropins with IUI, letrozole plus gonadotropins with clomiphene with IUI. What is your combination you will go for unexplained infertility? Simi is there? No. Simi I've asked actually. I think. Monica, you're not audible. I think you have to sign out and then come back again. Then Sakshi, she answered. Sakshi is there? No.
Sakshi ma'am is having some connectivity issue.
Okay. Dr. Indu, what is your choice you will take?
My take on this patient will be that she's 33 years, but she has not taken any treatment anywhere.
Yes,
so I will not immediately embark on IUI. I would like to give at least 2 to 3 cycles of ovulation induction and then see and then assess her ovulation by folliculometry, and that will make me wiser for the future treatment and future decision for the IUI medication.
I will go for ovulation induction alone without
3
IUI.
months, then 3 months IUI, and then we'll go for advanced treatment.
Perfect. Nivedita?
Yeah, madam, if the patient comes to me in the middle of the cycle or not on the day 2, then I will like to assess.
No, she's perfectly come on day 2 with all the other reports without any ovulation induction fresh to you.
Yeah, then I will go with the oral medication in the first cycle with letrozole.
Without IUI. Without IUI.
With this patient, first cycle I will observe naturally. I'll go
second cycle. When you go for IUI, what is your combination?
With letrozole, first cycle of IUI will be with letrozole. If egg doesn't form, then I may add gonadotropin.
No, she's a regularly ovulating patient. We have confirmed ovulation in her.
Yeah, ma'am. First cycle, then oral medication only.
Suppose you go for IUI the next cycle, what is your combination? Your preferred combination?
If she doesn't ovulate with the first cycle.
She ovulates. She's ovulating.
Ovulate, yeah. And then the gonadotropins can be, I would like to add on day 7 or day 8.
You will add, so a combination of letrozole and gonadotropins.
And additionally antagonist also I may prefer.
Antag also, okay. Now, Dr. Indu, what is the combination if you go for IUI after 3 cycles of ovulation induction?
I will go with gonadotropins.
Combination or plain gonadotropins?
No, combination.
What is the oral drug you will combine with your gonadotropins?
I will combine letrozole with the
gonadotropins. Okay.
And one more thing I would like to add here is that many times when we confirm ovulation, just by doing ultrasonography, it's very important. For what I have experienced is to do when we are seeing 1 good follicle or 2 good follicle, I prefer to do E2 at that time. Many a times we see good follicles, but estradiol level is 50, 45, 60. That means this may be empty.
So with which drug you are finding this less estradiol?
Mostly with oral ovulation.
That's what there was a discussion yesterday. That's because of letrozole. Letrozole is an estrogen antagonist at the local level, ovarian level, so it will cause a fall. But actually the follicle may be good also. So that's why they say if you're having a low estradiol with the letrozole, you should actually go for clomiphene citrate for induction for those patients. That is one point here too, because then doing a E2 is quite worthwhile. And they also, I think it's Sonia Malik madam who told us that E2 will fall in letrozole, and the other thing is letrozole, and the other thing is the follicles tend to rupture earlier in letrozole cycles compared to clomiphene cycles. For clomiphene, you need to go about 20 mm, but for letrozole, you should be careful. It can even rupture at 16 mm. So to be a little careful there. And then can I ask Yamini, what is your choice for IUI?
Ma'am, I would like to go with IUI in the first go, and with
IUI we've all accepted. I want the combination
with oral drugs for the first cycle, letrozole maybe, and if she doesn't conceive, then with letrozole and gonadotropin combination. Maybe day 2 to day 6 letrozole, and then 7, 8, 9 I might give gonadotropins and then monitor her.
Okay, Gayatri.
Yes, ma'am. I agree with Dr. Yamini. First cycle I would go with letrozole. And second and third cycle, I would additionally add gonadotropins.
Okay. I have asked everybody. Everybody has answered. Alka madam will give the final listing. Madam, what is your choice, ma'am?
Same. I will give letrozole, gonadotropins, and IUI.
IUI. Kanchan.
Yes, ma'am. Most of the panelists want to go with letrozole in the first
what are you using? Because now we are getting a consensus because everybody is having different protocols now. So what is your choice?
Okay, ma'am. In unexplained infertility, using a combination of like if we add gonadotropins, we get better success rate than by using only oral medication. And as such, there may be some subtle defect in ORs in the folliculogenesis. So gonadotropins definitely fare better. But to decrease the cost, we can do a combination with letrozole and gonadotropins. We can add both. So as such,
I'm totally confused. See, letrozole is supposed to cause a monofollicular development. And in
yes.
IUI, you want at least 3 follicles. So what is the point in starting with letrozole?
See, ma'am, actually, when we're adding both letrozole and gonadotropins, I'm adding both. When from the third day, I start gonadotropin and letrozole both. And my aim here in unexplained infertility is to get 2 follicles, because that will increase my success rate, because this is a normal ovulating woman. So in her case,
no, your plan of adding gonadotropins with letrozole is the FSH window. You want to prolong it for a longer time. So you want more of recruitment, right? But letrozole with gonadotropins will give you multiple follicles?
Yes, ma'am, I get 2 follicles.
No, not like clomiphene. It will not give like clomiphene.
It will not give multiple follicles. So we're actually defeating the purpose of doing an IUI for an unexplained infertility by giving letrozole combinations with gonadotropins. So probably with clomiphene, it will work much better. Let me tell you the evidence of what has been shown. Yeah.
Actually, ma'am, we are not using much of clomiphene in my practice. I use more of letrozole. So I'm
you know what? That's why I'm surprised, because for unexplained infertility, patient is already ovulating. So what is the point in giving letrozole for a monofollicular development? Because we want more follicles, more sperms, so that the pregnancy rate is much better. No, in IUI.
Ma'am, but the negative effect of clomiphene on the endometrium is more than the letrozole side.
You're adding gonadotropin with clomiphene, so the endometrial problem may not be there.
Our aim should be a bifollicular development in an unexplained already ovulating.
Because having a single egg is not going to help you in unexplained infertility unless if it's a cervical factor, which is very less. So your purpose may be defeated if you give letrozole combination. But let me tell you the evidence. So these are the what are the treatment options like? Typically involved ovulation. All are agreeing with ovarian stimulation, or you will just give a natural cycle IUI. Anybody is doing for unexplained infertility? Natural cycle IUI. Any of the panelists is giving? No, ma'am.
Usually no. But you can see first cycle. You can see whether she is ovulating or not, and if she is ovulating, you can go for a natural cycle.
Natural cycle
I think, but the results are better with gonadotropins and.
So ideally, you will give gonadotropins and then do the IUI, right, ma'am? Then you will not ideally to give a natural cycle IUI. So initially with oral medications, as all of you said, and then gonadotropins, and as all of you said, then if she's not succeeding, then IVF for those who are not conceiving with ovulation stimulation with IUI. The basic strategy which you're planning for unexplained infertility is you want to have more number of oocytes and sperms in the right place at the right time. That is a logic of managing ovarian stimulation in unexplained infertility. There are different regimes, and all of you have said that. So all of you said letrozole. So letrozole 2.5 to 5 milligram, right? Or anybody is giving at a higher dose for unexplained infertility. Any of the panels giving more than 5 milligram? No. And what about gonadotropins? What is the dosage and what is the drug you use? Let me start from the first now. I think I meant Monica is there? Or Dr. Indu, you can take the question. What is? Yes, please. Yeah.
Oh, thank you. No, we are using, as you said, we are using the gonadotropins. Mostly in my setup, it all depends upon the cost effectiveness, because gonadotropin cycles are also costly if you are using the recombinant.
If she's rich, what will you give? She's rich, what will you give?
Then definitely recombinant FSH gonadotropin is the better medicine.
IUI, even you will give, what is the dose? 75, 150, 225?
Yeah, we'll start with the 75, because in my setting, we are using the combined, we are using the letrozole along with the gonadotropins.
Gonadotropin, okay. Yeah. Okay, so you will give 5 milligram of letrozole with 75 milligram
2.5. I use 2.5 from day 3 to day, means for 5 days, and I use gonadotropins day 3, day 5, and day 7.
Okay, so you have that combination. Yeah. What about Dr. Sakshi? Dr. Sakshi? No, she's not joined. Dr. Indu?
Yeah,
what is a drug, madam, and what is the dose, and when will you start?
I prefer HMG, and to start with 75 IU with letrozole, and sometimes if I feel on the baseline scan that the follicles AFC is little low, I use clomiphene 100.
Okay, so you give clomiphene and like what Monica said, you will give it like 357 or
No,
it will
no,
be
no. No. I give from second day to sixth day. I give clomiphene or letrozole, whatever. But I start gonadotropin on day 5, 6, 7, and
okay,
then
so
again
it will be
scan
like
on
a
8.
fair step. Like you give
Yes,
clomiphene and letrozole, and then you add. Okay, two
I add on
combinations.
50.
Yeah,
Yes.
two combinations I've got now. Nivedita.
I usually use extended dose this letrozole 2.5 milligram BD for 10 days, and usually
10
I get
days.
the follicles. Yeah, and in
No,
some
no,
PCO I've
follicle
used
we
for
get anyway. She's a regularly
no,
ovulating patient. What about the
I get
gonadotropin?
around 2, and gonadotrophins usually I add from day 7. It is 75 urinary HMG.
Okay.
I prefer urinary and IUI cycles, and
So
if the follicle are not according, then I can add for 3-4 more doses after day 11.
Okay,
Yeah.
so it's basically you will give oral drug and then add gonadotropins like Dr. Indu is doing. Perfect.
Yeah.
Then Nivedita, what is your drug which you're using?
It was me, madam Nivedita.
Oh, sorry. Yamini.
Ma'am, what we are using is like 5 mg of letrozole from day 2 to day 6, and then HMG 75, day 7, 8, 9, and then we do a scan on day 10.
Okay. So Yamini, Gayatri.
Yes, ma'am. I also do the same. I start letrozole from day 2 to day 6. Day 7, 8, 9, I start HMG or FSH 75. Yeah.
Okay.
And day 10 scan.
Okay. Simi?
Ma'am, the same as.
Okay.
Yeah.
All of them. Monica, I've asked already. Kanchan.
Ma'am, I'm starting letrozole from day 3, and as I start gonadotropin HMG only from day 3 to 75.
So you start simultaneously.
Simultaneously, I start.
Perfect. So you don't give it alternate, you give every day.
Every day. Because
every day. Okay. Yeah, Alka madam. Okay, so we have got 3 combinations now. Very good. Alka madam. This is how a panel should be. Everybody should disagree with the other.
Yes.
Yes, ma'am. Alka ma'am, you're muted. Yes, ma'am. Yeah.
Yes, letrozole from day 3 or day 2 to 5 for 5 days, and then this HMG.
Okay. So what are your results? How many become pregnant in your practice with that protocol? Unexplained infertility. There should be a logic, no, madam, when you are giving.
Yes.
Any of the other panelists have noticed like how many became pregnant with this regime? Oral drug followed by a gonadotropin, oral drug with gonadotropin, oral drug with alternate gonadotropin. Any of you have noticed? Sakshi has joined. Sakshi, your opinion on that? Oh, you unmute yourself.
See,
Sakshi,
what
unmute.
I find with IUI also is very little. Of course, the results are better than when you don't give.
Yes,
but
yes.
then I think not much.
Not
10,
much of it.
10%,
Just to,
maximum.
Some are lucky, conceive. We don't even know how many conceive because we don't have a proper this thing of unexplained infertility in that sense. Sakshi, would you like to differ with anybody or agree with all of them?
Ma'am, I also practice the same thing. I do not differ over here.
How many become pregnant in your practice with that?
With gonadotropins, if the ovulations, oral ovulations are added with gonadotropins, the pregnancy rate in case of unexplained infertility is definitely much better. I would say rather it goes about 25 to 28%.
Oh,
whereas
great.
with oral ovulations, it is only 10 to 12%.
10 to 12%. Okay. So now I've confused everybody. So let me tell you what the evidence says. So the options we have already talked: natural cycle with IUI, none of you accepted. Clomiphene citrate with intercourse, none of you talked about that. Aromatase inhibitors with intercourse, none of us talked on that. Gonadotropins with the intercourse, no. Clomiphene citrate with IUI, no. Aromatase inhibitors with IUI, no. Most of us use a combination of clomiphene citrate or letrozole with gonadotropins with IUI. All of you said about low dose gonadotropins. None of you went for conventional dose, which is more than 150. And then we'll come to the question of timing of IUI, IVF, and other treatment paradigms. There's a strong evidence that when you do IUI in a natural cycle, that is equal to just waiting, expectant management. So it's actually useless. Clomiphene citrate with intercourse, not effective at all. It's equal to expectant management. Letrozole with intercourse, same, no use at all. Gonadotropins with intercourse, you may have a better result, but remember you will have multiple pregnancy if you go for conventional dose of gonadotropins. And clomiphene with IUI, there's a strong evidence that actually clomiphene with IUI is superior to expectant management and natural cycle IUI. Not much better than adding gonadotropins, but with clomiphene with citrate with IUI is much better than expectant management. And this is the first point where you say that because with clomiphene you've got multiple follicles, but if she's got an endometrial defect with clomiphene, it may defeat the purpose. Then with one or two cycles, you will know, as Dr. Indu said, see how her endometrium is behaving with the oral ovulation. And if she's not conceiving, then you add gonadotropins and think about IUI. Letrozole with IUI is similar to like clomiphene. There is no significant difference in pregnancy rates or multiple gestation rate following letrozole with IUI. It is comparable to clomiphene citrate with IUI. So as most of you said, if you want to do, you can go do just letrozole with IUI, even if it's a single follicle. Evidence says it's equal to clomiphene citrate and IUI. But when the combination happens, it's supposed to be one of the better regimes because of cost effectiveness as well as the results. So clomiphene citrate and conventional dose gonadotropins, it's not low dose gonadotropins, are associated with a higher pregnancy rate and also a higher multiple gestation rate. You have to be ready for that. And then suppose you give low dose gonadotropins with IUI, they say it is equal to just giving an oral drug. So if you are wanting a result with IUI, you have to go for conventional dose gonadotropins and not low dose gonadotropins. If you want to have a cost effective method, you have to add clomiphene citrate. With clomiphene citrate, if you've got an endometrial problem, it's better if you add letrozole with gonadotropins. Kanchan's protocol of starting oral ovulations with gonadotropins is much better because you will have more than one follicle developing when you have an oral ovulation with gonadotropin and a better endometrium, because clomiphene can cause problem. And if you and that alternate day regime is still more cost effective. But that is low dose gonadotropins, which you said 75, which may not be effective. You have to go for more than at least 150 to get more than one follicle. And IUI with conventional dose gonadotropins will give you better results, but high multiple gestation rate. So let me summarize. If you give with natural intercourse, oral ovulations, or if you give IUI with unstimulated, it is useless. With natural intercourse, variable results, you can have pregnancy, but it may be multiple pregnancy. Letrozole or clomiphene with IUI, better than expectant management. Clomiphene or letrozole, same thing, better results, but higher management. Then IUI with low dose gonadotropins, remember, it is not better than oral drugs. Actually, you're just adding the cost, but without much of results. You have to go for conventional dose gonadotropins. So that will give you a better pregnancy rate, but higher multiple pregnancy rates. So regarding the timing of IUI, can I ask Dr. Indu on this? Do you think double IUI or doing IUI at 24th hour, 40 hours, any difference it will make in unexplained infertility?
No, in my practice, what evidence says is also it's almost similar. In my practice also, I've tried both ways, single IUI and double IUI. Results are the same. I prefer to do IUI after 34 to 36 hours of treatment.
Yeah. Anybody would like to do a double IUI? Anybody are doing and getting better results?
There are certain, I would like to add to this.
Yes, sir.
There are certain special conditions where the double IUI is definitely useful when we are doing a donor sperm. Because when we do double IUI, we improve the concentration of the motile sperms at the time of ovulation. And in cases where there is subtle male factor infertility, subtle changes, subtle defects in the semen parameters, there I would prefer to do a double IUI with the thought that
in unexplained infertility, how many IUIs you'll do? Single or double IUI? Unexplained. Donor, you say that's okay, but unexplained.
In unexplained, a single well-timed IUI is the thing.
Much better, yeah.
Much
better. No benefit of doing double IUI.
Double IUI, yes, ma'am. And what about IVF? When will you go for IVF? Can I ask? I'll start from Nivedita now. When will you go for IVF? You've done how many cycles of IUI and then you'll go for IVF?
After 3 to 4 cycles of IUI, I would like to go with IVF.
IVF. All the others would agree, or anybody would like to go a little later or do some other optimization and then go for IVF? Anything of that sort?
If she is 35, we can wait for 6 months. And then go higher. And if she is more elderly, around 40, then I think
straight away for her. Straight away for her. Yes, ma'am. Yes.
And in case of donor, if IUI is being done with donor sperm, then we should at least try.
We are not, Sakshi, that's a bad word now. We are talking only about unexplained infertility. We are not talking about donor because we are not got ART banks still, so we are not talking about it.
Okay,
unexplained infertility. So all of you agree that after 3 to 4 cycles of IUI not succeeding, patient more than 35, straight away for IVF, less than 35, ask her to wait for 6 months before proceeding with IVF.
Yes.
Immediate IVF, yes, yeah. Anybody? Somebody said something.
Yes, ma'am, I'm agreeing with Dr. Nivedita and what you have told just.
Okay, yeah. So immediate IVF, we have discussed on that. And actually, there's no reported evidence between compared between IVF and ICSI. But how many of you go for ICSI straight away for unexplained infertility? This is a burning question. Because with less period of infertility also, many of us do ICSI. But for unexplained infertility, what do you think is right? Can I ask Yamini?
Yes, ma'am. We are going for ICSI maybe because there might be some sperm DNA fragmentation or there must be some.
So you're muted. Please unmute.
So by doing ICSI, we are overcoming at least those kind of things so that at least the fertilization will happen. And
okay. Anybody would go for IVF compared to ICSI?
Yeah, if egg numbers are good and if the semen parameter is also good, then we can go with 50-50, like not all ICSI with 50% IVF. ICSI ensures fertilization, that is something, but with if sperm parameter is good, we can do 50% IVF.
Yeah, that's a practical way of tiding over a potential crisis. So suppose you don't have any embryo formation, the patient is going to kill you. So at least half and at least show her the embryo there. So IVF is better for which group? It's actually for a younger woman, it's supposed to be much better. Because you may be just having occult ovulation defects, and when you do an IVF, the results are better. It's good for occult endometriosis. And suppose there's a subtle difference of tubal function, these are the patients who will benefit from IVF and male factor. And the older women actually are less responsive to IVF, and we need to go for ICSI because IVF cannot improve the oocyte quality. Same for ICSI also, it cannot increase ovarian results. So you have to work with whatever you're having. So second patient, I'll just go through quickly. 30 years old, regular cycles, married since 5 years, no history of sexual dysfunction, BMI on the higher side, vitals normal, thyroid profile normal, ultrasound normal, semen analysis normal, any other investigation needed for her. We have done a semen analysis, ultrasound. Okay, what is the other factor you will see?
Tubal factor?
Yeah, tubal factor, yes ma'am. Tubal factor should be checked for. And then
ovarian reserve.
Yeah, yes.
Ovarian reserve, ma'am.
Ovarian reserve. So AMH you'll want to do. You'll want to do
AMH and the annual follicular count.
Follicular. What is the treatment you will offer her? Gayatri.
Depending on the first treatment that I'd like to offer is for a lifestyle modification, as a BMI is 35.
She won't listen to you. She won't listen. Then.
No, but that we need to emphasize on.
There was a recent article in ASR, the fertility sterility, where they said if you ask an obese patient to lose weight, many of them would have tried for a long period of time and they would have come actually desperate to have a child. They said there's no point in waiting with obesity because obesity does not matter so much, it seems, at the end point for infertility. That's what the study says. Would you agree with that?
How old is she, ma'am?
She's 30.
She's 30. Okay, ma'am. And because of her BMI, if her BMI is 35, another thing that I want to see is her sugar profile also. If her she is not, I mean her sugars, ma'am. I would like to see her sugars, her fasting blood
normal.
sugar.
Sugars are normal.
Yes, ma'am. And most of the times, even with this BMI, there is also sometimes sexual dysfunction also is seen among such couples. So we also need to take a proper sexual history, whether that is also could be a part of could be a reason of infertility.
So what is the treatment you will offer if she's got sexual dysfunction?
Then the best treatment is to offer her at least 3 to 4 cycles of IUI. Yes, but her tubal factor needs to be assessed and her ovarian reserve also needs to be assessed before we take the decision of
her BMI is 25, tubes are fine, and she has got a good ovarian reserve. What will you offer?
Yes, ma'am. So that means if she's falling into the category of unexplained infertility, then as discussed, we will go ahead with the first line management of IUI.
Okay, perfect. So we have finished this case. So third patient, 31, married since 5 years, same thing. Husband is a diabetic, BMI normal, galactoria, thyroid profile normal, AFC is only 6, semen analysis is fine. Any change in treatment based on male parameters for this patient? because she's got a 25% rapidly progressive. Can I ask Simi?
Yes, ma'am. As in this case, husband is diabetic. So the
sugar, if you control the sugars, then what? Then still the male parameters is showing a low progression there. What will you do?
There will be the DNA values. What is it? Like
how many of you do DNA fragmentation test? What method you do? You do, Simi, DNA fragmentation in your center?
Yes, ma'am.
What is the method you use? Sperm chromatin. What is the test you use? Tunnel. Anybody like, okay, you done a DNA fragmentation and is showing a problem. What is the treatment you will give her? She's not undergone even IUI now. What is the treatment you will offer? Simi?
Yes, ma'am. Ma'am, for the DFI, if it is raised, then there is no treatment which can control it, but the prognosis can be explained to the couple that this is the situation. Yes.
Okay. And suppose they want a treatment, what will be your choice?
Antioxidants you can give.
Antioxidants. How long you will give, madam? Antioxidants for how long?
3 months. Ma'am, but it will not be effective.
So 3 months of antioxidants given. They've come back again. What to do now?
Then the rechecking, what is the motility of the
still motility is low, still low. See, these are the patients we usually get.
Then they must be counseled about that. What is the age in this case, ma'am? The patient
she's 30.
She's 30. Still not waiting for 31. Much. She must be explained about the IUI followed by the IVF. In this case, the IUI should not be. Yes.
Yeah. So treatment should be offered. That's what I'm asking.
Yes.
Any ovulation induction for her, or you straight away go for IUI for her?
Yes.
Straight away IUI, ma'am?
No. Yes. Motility is low. Why to wait?
Okay. IUI straight. Antioxidants we gave according to your advice. Given her antioxidants and we went for IUI. Then can I ask Monica? Do you agree? With all of us, we are saying she is having a mild male factor. DNA fragmentation we did. It is abnormal. So we are going for IUI. Is it okay for you?
Yes.
Monica? Yes. Yeah, perfect. Okay. Indu?
After first IUI tried just for 2-3 cycles, then for IVF.
Yeah. Kanchan?
Ma'am, in such case, what we are doing actually is first lifestyle modification for the male factors, control his sugar, antioxidants for 3 months. And I call the patient back again and I check his semen parameters and DFI. Supposedly it's again raised. And the motility is also less. Then of course, as a mild male factor, I do IUI. But ma'am, we are adding MAX here, magnetic assorted cell sorting. So in patients where the DFI is more, I'm doing IUI specimen preparation by double density gradient and max, and then we do the IUI.
Okay. So this patient, suppose they've got a normal DNA fragmentation. If they undergo an IVF straight away, the pregnancy rate is 12.7%. Suppose it's an abnormal DNA fragmentation, and if they undergo ICSI with ejaculated sperm, the pregnancy rate is 18.7. And this will include failed IVF patients also. Suppose they've got an abnormal DNA fragmentation with a failed ICSI, it's better if you go for surgically retrieved sperms compared to ejaculated sperms. This was a study which came out in 2018, and they put up this algorithm. So DNA fragmentation, it's worthwhile doing for a person with unexplained infertility, and they've already tried all the methods. And if you do a DNA fragmentation, you find it normal, still you can go for IVF. The IUI is failed. So your first line of treatment will be IUI for unexplained infertility, and you do a DNA fragmentation. If it's normal, IVF is the best method. But suppose they've got an abnormal DNA fragmentation, it's better if you go for ICSI compared to IVF. And you do it with ejaculated sperms, and that will give you good results. But if she has failed that ICSI cycle and she's got an abnormal DNA fragmentation, do the ICSI with surgically retrieved sperms. This was one algorithm which came out in 2018. So tubal flushing, any of you do for unexplained infertility? That is, they do HSG and they say that many conceive with that. Anybody is doing with that?
See, many people used to do UTCI. So if you consider it as tubal flushing, then
they use that now, madam. That's something the gentamicin they used to put 25 years back.
Tubal cortisone insufflation they used to do.
Okay,
Yeah.
so something like that tubal flushing, but none of us, I think, are practicing in our practice nowadays. Anybody is doing now?
No.
No.
But it is very
Very useful. Not so useful. Fallopian tube sperm perfusion, anybody is doing in Dr. Hindu?
No.
Instead of IUI, a sperm perfusion?
No.
You think it helps? Because there's one study which actually said, I think 15 years back said, you put 4 ml of cement volume inside after preparation, they say that gives you better results. Have you tried that? Sperm perfusion? No. So actually, it has to be done by laparoscopic approach, but we used to do with the IUI catheter. So that's useless actually. It will not even get into the ostia there. So, but if you do it in the laparoscopic approach or with transvaginal tubal catheterization, they said it gives a good result, but the disadvantage is it can cause patient discomfort because you're not doing it in anesthesia if you're doing it with a transvaginal tube, but laparoscopy will do it under anesthesia. There's always a risk of infection when you're putting so much of fluid inside the tube straight away. So do not, I think not much used now, probably it will come back with some modifications later on. So this is a nice guideline for unexplained infertility. Regarding fallopian sperm perfusion, it came out in 2004, but now they're saying it's not useful at all. So the take-home messages for this talk will be treatment for unexplained infertility. Suppose she's a short period of infertility and she's a younger age, you can give her expectant management. And when you want to do the treatment part, it has to be combined with ovulation induction with a drug which will give more than one follicle, which will give better results. IUI with or without ovarian stimulation should be added on, but with ovarian stimulation is always better. IVF will be the next option for these patients. Do not offer IUI routinely for patients with unexplained infertility who got regular unprotected sexual intercourse. You can ask her to wait for 2 years and then straight away go for IVF. It seems to have much better results than going through the cycles of ovulation induction when she's already having ovulation. Adding IUI when she's got a normal sexual life then may not help. Even IUI may not help. It's worthwhile considering IVF. So this was one algorithm, and I think Alka madam also mentioned this. Less than 35, married only for less than 2 years, expectant management is worthwhile for the next 2 years. If it's more than 2 years of waiting, then straight away go for gonadotropins with IUI for 3 to 6 cycles. Oral ovulations you will need to add only for the cost effectiveness. The patient is affording, giving a conventional dose gonadotropin and going for IUI is much better. 35 to 39, waited for more than a year, straight away for IUI with gonadotropins and then IVF. More than 39, as Alka madam said, there's no need to wait, but if she's insisting, probably 2 cycles of IUI and straight away go for IVF. Thank you so much, Dr. Monica, and all the esteemed panelists and the expert, Dr. Kanchan, Dr. Nivedita, Dr. Yamini, Dr. Gayatri, Dr. Simi, Dr. Monica, Dr. Sakshi, and Dr. Indu, and a special thanks to my beloved Alka Pandey madam. Thank you so much.
Thank you very much.
Thank you, ma'am.
Thank you, ma'am. Thank you. It was very nice to be in this panel.
Monica disappeared.
Mila,
Madam.
People say this what you were saying that letrozole does monofollicular development, gives monofollicular development, and this clomiphene there are multiple follicles. So will the chance of twin pregnancy or multiple pregnancy will be increased with
that balance is there. You go for more follicles, it's a more chance of multiple pregnancy. You have to accept that risk.
Yeah.
Otherwise, better to go for IVF and a single embryo transfer you do.
Yeah.
If she does not want the risk of multiple pregnancy. That's the only option we have.
Yes.
So Arun sir has joined. Sir.
Who?
Yeah, Arun Madhav.
No, I'm already, I have not joined. I was hearing everything, whatever you say. But what I like to little disagree with you regarding this is that the studies that you said are all of the European studies.
Yes.
Yes, we do not have an Indian study for an unexplained infertility and IUI. But that is the time now when we should actually create and develop our own data. See, every center has their own data. As you said, a lot of new regimes you are hearing in every panel. But nobody is really publishing their studies to create an own data to say that we in India have this protocol because of the cost factors, because of the different ethnicity or whatever we can call it. So some regimens can be incorporated even though it is not being really in the guidelines. That is what I would like to say, but with an insistence to everyone that we keep on adding new things and new ideas with publication so that in near future we can create our own guidelines, maybe through Fogsi, maybe through ISAR, or maybe through different heads, but our Indian data are really required for our own guidelines.
Yes, sir. For almost every this thing in obstetrics and gynecology, we need Indian data, but we are not putting it up. And I think these panels will help. Now we had different opinions from different zones actually. All of them had different ideas, but I think we came to a consensus. Would you not accept the panelists? Didn't we come to a consensus? No, we still disagreed at the end.
I was on the panel, right? Sharmila, I cannot miss your panel. I told you that day. I cannot miss everything because
we came to a conclusion. Like we'll do this, right? Or we agreed and then we disagreed and then we came to an agreement. That's what I thought.
Right.
But we'll put up data because Kanchan is there. Kanchan, she's a very capable person. You can ask us for data. You can put up a multicentric trial, unexplained infertility. We'll give you the data. We have already done one data collection.
She's our new incoming secretary of the NESR now, Kanchan. So she'll be really compiling her own data and also helping others to help her publish data.
It's really necessary, sir, as you said, because our population is totally different. And all of you are using letrozole with gonadotropins and you're saying you're getting good results, but we're not able to put it up boldly because we are not collecting that at all. So if you put up the data and say it's a very cost-effective measure for unexplained infertility instead of going for IVF, which is so expensive. So I think we should put up the data at one point of time. Alka Madam, Vice President.
Yes.
And just to make the thing little more confusing, I have been off late using both letrozole and clomiphene in the same cycle and to a great satisfaction in last 25 of my cases. So I'm preparing my own data to see whether that particular combination suits our people or not.
Actually, there was a study which came in 2018 where they used letrozole with clomiphene from day 2 and they did an IUI and they got good results. In Chennai, there's a person who's doing a study on that. We will bring out the data. She's compiled 40 cases where she has given clomiphene first, and then on the day 6 or day 7 when there's no follicular growth, not day 10 she did. Then she added after day 10 letrozole or clomiphene, which has given the other drug before, and she said she's got excellent results. From COVID time, she started this study. So we'll give you, she's already collected 40 cases. So once she does that, we will publish and we'll show you also.
Arun sir has done, na? He is also sir, you also have done the same study, na?
Yes.
Sir has got 25 cases. You can, I'll give the number to you. You can talk to her and you both of you can compile together.
Sure.
Thank you so much. Monica, can we?
Thank you, Monica. Yes, ma'am. Thank you so much, Arun sir, for waiting till the end. Thank you, Alka ma'am, and thank you, Sharmila madam, for an excellent moderation and taking out the best in our panelists. Thank you all the esteemed panelists for an active participation and helping us to reach a consensus. That is the main aim of these webinars, so that we can installate some scientific content to our obstetricians as well as doing a public awareness activity. Thank you, Tushar sir, for joining us and gracing the occasion along with Arun sir. Thank you, Kavita ma'am and Sujata ma'am for your talks. Rekha ma'am, Nivedita ma'am for being the chairpersons. And thanking Rishikesh Pai sir and Priyankur for giving us an opportunity to conduct this webinar. And thank you, Corona, for the academic support. I'm delighted to say that there were almost 250 participants viewing this program online. This is apart from the YouTube views. Thank you so much, everyone.
Thank you,
Monica.
Thank you so
Thank you,
much.
ma'am.
Thank you so
Thank you,
much.
ma'am.
Thank you, Sharmila.
Thank you, ma'am. Thank you. See you. Thank you.
Thank you, Arun
Thank you.
sir.
Thank you.